Welcome back to the conversation. Today I have the esteemed Dr. Joel Kahn. Hi, Dr. Kahn, welcome.
Esteemed, STEAM, because I ate so much steamed spinach. You got it.
That's the one. Well, in my mind, very esteemed. Let's introduce you to our audience. I don't know how anyone watching doesn't know you, but you're a cardiologist, triple board certified in internal medicine, cardiovascular medicine, and interventional cardiology. You're also a clinical professor of medicine, and you're known as America's Healthy Heart Doc. And viewers can actually find you working still at your Kahn Center for Cardiac Longevity in Michigan. And I have to tell you that my journey to you occurred several years ago after you did a podcast with James Maskell's Evolution of Medicine.
Right.
And I heard that podcast, and your interview was the thing that opened my eyes to possibility that there was something beyond what we're doing in Western medicine. So you are a huge impact in why I'm sitting here right now hosting a summit, why I am doing what I do. So thank you so much for the impact.
I appreciate that. That was a real special evening, and I'm glad it made an impact on you, and I hope a lot of other people will do that again right now, I hope.
Yes. Okay, so we're talking mitochondria today. You are the expert on this summit about heart and heart health. So we're going to get into, what's important here about mitochondria and why this is so important for heart health. So could you start with sharing, let's talk a little bit about statistics and what's going on with people in their heart health.
Yeah. And, they have to be repeated because they're so shocking. I mean, we get dragged down various health concerns. We got a big fentanyl crisis going on. We've obviously had the pandemic. We always have cancer issues and, horrible. But still, more people will die this day, this month, this year from cardiovascular disease, the whole umbrella of heart and blood vessel related illnesses, than any other. And the last statistics I saw were about 2022, about 700,000 Americans a year die of cardiovascular disease, just ahead of cancer. But it's been that way for 105 years. We're number one. It's not a title you really want. And COVID got close a couple of years ago, but it's dropped back off, thank goodness. And some shocking numbers, and I don't really memorize these, but 1,000 people a day drop dead suddenly. And, it's sad if you're an older person with congestive heart failure and you're slowly dwindling and the family's around you. But to kiss a loved one or a father or a mother or a sibling or a parent goodbye and never talk to them again because 1,000 people a day drop dead of cardiovascular disease. That's called sudden cardiac death. And it seems like lately we read about that a bit more. Actors, musicians, athletes. It's in the headlines a bit more, and it may actually be a bit more post-pandemic. Some of it is controversial post-pandemic bad lifestyle choices. COVID itself may have some impact on our blood vessels through spike protein damage. That's the viral illness COVID. And of course, there's controversy about the vaccines and damage to arteries. I won't go down that path because we'll get shut down and they won't let us talk anymore. But that's the issue. And, and I just want to pose a question. And I think I posed the question sort of in that James Maskell conversation of a couple of years ago. You're getting to be 40, 45, and you have a standard doctor or a functional medicine doctor, and they mention things like a health checkup, like maybe a mammogram, or you don't believe in them and you get a thermogram, or you get a colonoscopy, or you get a Cologuard. I challenge you to say who's been told by their primary care doc, and maybe even their functional doc, check your heart, check your mitochondria in your heart, because you're statistically more likely to drop dead. And there's sort of an assumption that doesn't exist, that we have a breast cancer screening program and a cervical cancer screening program and a prostate cancer screening program and a colon cancer screening program. But you just go through life, and the problem is heart disease slowly develops in those that it develops until the day that it can be, suddenly tragic, either a heart attack, emergency room, or death. If it reliably gave us years of warning, we could listen carefully for those clues. And maybe the most reliable one in guys is erectile dysfunction. Erectile dysfunction may be 3-4 year warning period before there actually might be heart symptoms, heart attack. It's not as clear that there's such a clue in women. It might be fatigue and back pain and palpitation. But the bottom line, the sole message is, for the next few minutes that we're conversing, let's talk about, this amazing burden of heart disease, the impact it has on heart function, which relates to mitochondria, because mitochondria drive the heart, make the heart function. And, early detection, be as aggressive. And this, frankly, I listened to your introduction. I mean, I try to avoid excessive Western medicine. A lot of what I do with patients is reassure them, you don't have heart disease. You don't need those prescription drugs. You just need a lifestyle. And some of it is really application of very high-tech Western medicine. And that's where we're talking about here, early detection of heart disease. So we got to drop these numbers. They're just tragic numbers.
What impacted me when I listened to that interview all those years ago was your discussion about how you are an interventional cardiologist and you did a lot of procedures, put a lot of stents into people. And then you came to this realization that that wasn't the solution and that there were other ways to help save people's lives. And that wasn't working. And that's when my eyes opened big and I went, what? A cardiologist is saying we should be doing less procedures and doing more lifestyle things.
In fact, I've given up doing what are very lucrative procedures, catheterization and stents, to focus solely on usually lower paying preventive strategies. But it's the right thing to do. And frankly, it's a wide open field. There's lots of cardiologists doing procedures, and there's sadly a very small percentage that are talking, as I say, hashtag prevent, not stent. Why don't you never get heart disease? Or why don't you find out about it so early that it never becomes a serious problem? These are very doable. They're actually not elite or expensive concepts either. And just to tie it in, we'll have a healthy heart with healthy mitochondria. Let's just take mitochondria for a minute, because I do want to give justice to it.
Mm-hmm.
We've got we don't think about it. We're all busy with our life. We got this gorgeous heart beating 60, 70 times a minute, over 100,000 times a day it's beating. And it requires tremendous energy. I mean, we pump this little tiny little muscle, the size a little bigger than a tennis ball, pumps over 5 gallons a minute of blood through the body like a torrent, all the way up to the brain, all the way down to the toes. We got to get it all the way back up to the lungs to pick up oxygen. It takes tremendous energy. And we've also learned it doesn't just take energy to contract and push the blood through the body. The heart has to relax and let the blood fill back up for the next cycle. That takes energy too. It's energy, it's energy, it's energy. And I believe the statement is correct that there's more mitochondria per cell in the heart than any other organ in the body. I know the brain is pretty close, and I don't want to absolutely say that the heart is overtaking the brain, but given the intense muscular activity of the heart, I think it is the heart's number one for mitochondrial density, and it requires lots of blood flow. And we're talking here about early detection of heart disease. You want healthy heart muscle and healthy mitochondria. You need healthy blood vessels, big blood vessels, and there's also the small ones called microvascular circulation. You want to keep them all healthy. And you want to have the right nutrients so your mitochondria work. And, the single most scientifically backed supplement in the literature, not Joel Kahn's opinion, is actually coenzyme Q10. A recent giant meta-analysis of almost 1 million subjects found that if we used coenzyme Q10, sometimes called CoQ10, sometimes called ubiquinol, but mitochondrial support for the heart and other muscles, but it's usually used primarily for the heart, lowers blood pressure, lowers cholesterol a bit, takes away palpitations, is great for migraines, many other uses for CoQ10. You actually can reduce cardiovascular death by about 1/3. And many vitamins, we don't have that data. People joke about vitamins are expensive. Urine and standard doctors and cardiologists often tell patients you don't need that long list of supplements. But if you got coenzyme Q10 on there, you got better mitochondria.
Heck yeah.
Than previously. And, I do consult on a lot of patients with shortness of breath, actual congestive heart failure, sometimes hearts that have been weakened by previous heart attacks or blood pressure. And that's a mitochondrial disaster. And we have so much to offer there. That's some of the most biochemical kind of game plan. How can I support your heart's mitochondrial pathway? Part of it is eliminating toxins, things like heavy metals and
Mhm.
pesticides and organophosphates, and just a super, super clean lifestyle, and heavy metals particularly. It's very easy, for there's again, it's not new age. It's in our cardiology literature that an accumulation of cadmium, lead, mercury within the heart itself can cause serious disease, and is very common, and can be very lethal, and can be measured, and can be, worked to detoxify and eliminate. It's certainly not a standard part of medicine, but it's important. And I urge everybody, get that done, get some heavy metal testing. We live in 2023 where we're in polluted area, and get your mitochondria working better by eliminating toxins. And then you can create this whole mitochondrial support with coenzyme Q10 and ribose and taurine and sometimes magnesium and L-carnitine. And there's all these other wonderful prescription drugs for people with advanced cardiac disease and heart failure. But usually my role is to bring in a bit of the natural and layer it on top of the standard. I can't discount all the advances that have happened. But so I just wanted to spend 5 minutes on mitochondria, because the heart is a mitochondrial organ, and it's just something not talked about a lot when you go visit your internist or your family doc or your cardiologist.
Yes. So I would love if we can have a discussion, if you would, about cholesterol.
Yeah.
So could you let us know? I mean, I feel like there's a lot of conflicting information out there about cholesterol and what is the good number. I can remember back when I started practicing medicine 20 years ago, the level of LDL that was acceptable was around 130. Now it's around 100. I prescribe more statins than probably any other drug. And I would love to know what your thought is on this. I get people asking me all the time, how do I do this naturally? What's really dangerous? What's really safe? And also, can you talk about what is the important thing about cholesterol? And are we doing damage by lowering cholesterol too much?
Yeah, and I'll give you my spin on it, but it's a spin from a lot of patient care and a lot of research and writing and learning. In fact, I was listening to a 45-minute lecture on this topic just before I signed on the Zoom. I had a little break between patients. Cholesterol wouldn't matter if there wasn't some evidence that in some people, cholesterol accumulates in blood vessels, in the lining of blood vessels, the endothelium and the intima blood vessels. And cholesterol can be part of the pathology that narrows blood vessels and causes symptoms like shortness of breath or angina, chest pain. Or cholesterol could be part of the syndrome that causes heart attacks, strokes, and death. There's no question. The pathologist told us, over 100 years ago, if you have a clogged artery in a leg and a brain and a heart, part of the chemistry of that garbage in the artery is the chemical cholesterol. I mean, there isn't sugar in arteries. Absolutely, excess sugar in the diet is a factor in poor health, including developing clogged arteries. It's taken a while to get to that conclusion. But there's absolutely cholesterol in the arteries. And the only question is the level in the blood related to what's in the artery wall? Is the level in the diet related to what's in the artery wall? These have been very, very tough questions over the years. So our liver makes cholesterol. Is that good? It's absolutely good. We absolutely need cholesterol to support our hormones and our sex hormones and our cortisol and our vitamin D. We all know that. Are there some people is there any really question that in some people cholesterol damages arteries? There is not. There's a type of scientific analysis called MR, Mendelian randomization. There are people born from birth, that's redundant, that make a little more cholesterol than the average public. And there are people due to genetics, SNPs, and there are people that are born that make just a little bit less cholesterol than the average in the public. And because that difference starts at birth, it's through your whole life. By the time you look at them at age 40 or 50, the amount of heart attacks, strokes, deaths is dramatically different. There's really no controversy and I keep emphasizing, in some people, an elevated, predominantly LDL cholesterol, it can lead arteries to become diseased, leading to what we call strokes, heart attacks, bypass stents, and dying. The challenge is we're so different biologically. My favorite word in the last 5 years is precision medicine, or I already got a second favorite word, personalized medicine. And this is the challenge. And this is what has become so hard. You mentioned we got two people relatively similar, 45 years old. One has an LDL of 130 LDL cholesterol, and one has an LDL cholesterol of 130. They may be dramatically different in how their arteries are. And the current medical model is they're both going to get 10 milligrams of atorvastatin, Lipitor, hopefully after 3 to 6 months of some diet, exercise, weight loss, lifestyle recommendations, but probably not. But they can be very different. So one of the biggest and most important messages, please everybody just write this down, is people that don't have atherosclerosis scientifically don't need prescription medicine for cholesterol. I have patients in my practice, this may sound radical, and I'm a statin prescriber, and I'm a cholesterol believer. But if you have a heart calcium CT scan done, $75 test, $99 test, and it comes back 0, and you're about 45 or 48 or 51 years old, the science is overwhelming. You do not benefit from prescription drugs. And you can allow the LDL cholesterol to stay elevated. There was a recent study in 2023 called the Western Denmark Heart Registry. LDL cholesterol is over 190 with a calcium score of 0, did not result in an increased risk of any cardiovascular damage over about 4 years in part of the study and 16 years in the other part of the study. It's not to encourage people to have a super high cholesterol, but it's to ask the question, do I have a super high cholesterol and clean arteries, or do I have a super high cholesterol and I'm starting to develop the disease? And there's 2 tests. One is an ultrasound of the carotid arteries. The best version is called a CIMT, carotid intimal medial thickness ultrasound. Quick little test, no radiation. You got no plaque, you probably don't need prescription therapy. Work on your diet, eat a little more oatmeal, have a couple more edamame, have a little ground flaxseed on your salad or something, and get some gym time in. But if you've got plaque and it says, you're 45 years old, but your arteries are like a 57-year-old man or woman, you probably need to get a little bit more aggressive. And then even probably a little better is this heart calcium CT scan. Requires a prescription, usually from a provider, is less radiation than a mammogram, no injection, no needle. It's available at every hospital in the United States, except for the smallest. And if you have an LDL cholesterol of 150, but you have a heart calcium CT scan of 0, even the very stodgy American Heart Association says you do not benefit from Lipitor and Crestor. You benefit from concentrating on lifestyle and diet. So it's not such a simple black, white, yes, no. It's about precision medicine, but it's so easy and inexpensive to get these vascular tests and ask the intelligent question, why am I taking a drug if I don't have a disease? If you don't have a disease, you don't need a prescription drug. If you have the disease, and we should be getting these heart tests, either the harder to find carotid ultrasound or the simpler to obtain heart calcium CT scan. Just like we think about a mammogram and a colonoscopy and a digital rectal and a cervical exam in a woman. This should be a routine part. It should be more important than all the others because heart disease is so much more common. And do it around age 40 or 45 and repeat it in 5 or 7 years and sort it out. Now, I just want to go off a little bit more. Cholesterol is a risk factor for early heart attack, stroke, and death. It's not the risk factor. There's many. There's 20. My mind always is blown off, little fireworks when I'm seeing a new patient. What's their blood sugar, insulin resistance? What's their lipoprotein A, the other cholesterol that about 20 or 25% of us can make in our liver and 75% of us can't make. That's how I explain to patients. 100% of us make LDL cholesterol, and maybe 20 to 25 make 2 kinds of cholesterol. The other one is called lipoprotein A, and it can be very, very important in people. Simple little blood test. Everybody should have once. And I said insulin resistance. What's your blood pressure? Blood pressure is the big elephant in the room in so many people. What's your sleep status? What's your sleep apnea status? What's your inflammation status? TMAO. I won't go off on a tangent. Nitric oxide production, endothelial function. So you can have a high cholesterol and clean arteries because maybe all those other factors are in good shape. And you can have a relatively modest LDL, even in a totally normal range, LDL cholesterol, and have abnormal vascular studies, because maybe it's something else. Maybe it's the lipoprotein A. So I don't want to make it too complex. It's actually pretty simple. You need about 10 blood tests and one or both of these vascular imaging tests. And you're in a, really precise precision place to know, am I in good shape? Am I rotting? Do I need prescription drugs? Do I just need arugula? What's the plan?
Well, I think this is really important. So everyone watching right now, your time of investment of watching this summit is worth this 5 minutes that you just got from Dr. Kahn, because here's what I know. Working in family medicine and internal medicine for 2 decades, not everyone knows, who has a prescription pad, what you just said. So what many family practice doctors are doing is just looking at the cholesterol level and just gauging, well, you need a prescription based on this, and they don't know. What is that?
I don't know if that's going to be something people can read, but just to tell you the frequency, I mean, I have a pre-printed prescription pad.
Mhm.
You should encourage your provider to have the same.
Mhm.
It's, there's no iodine injection. It's, officially a CT calcium scoring. There is a CPT code. That's what the insurance companies want, but this is self-pay. Usually you pay $75 or $99 and get it done. I just wanted to point that out,
Yeah,
because
so worth it.
that's what primary care doctors should have, and say, okay, here's your script for your colonoscopy,
Mhm.
for your mammogram, and here's your heart calcium CT scan. And let's define if you're at risk or not, because there's 1,000 people a day dropping dead. Most of them would have flunked that test big time, and we
Mhm.
would have had years to get a stress test, evaluate the full spectrum, like I said, of all these blood factors that are promote atherosclerosis, and then institute a plan of hopefully mainly lifestyle and supplements. Really cool data. I'll just give a shout out. I've been waiting for a study that berberine, which is a very commonly used supplement in the integrated world, may reduce atherosclerosis. So the first human study with berberine showing it helps shrink plaque came out.
Wow, I'm surprised. Who funded that? There's no money.
Yeah, actually, it's the Chinese, it comes from China because berberine is part of traditional Chinese medicine. It was a small study, but I just point out there's so much. So, Doc, why do I want to know if I have some plaque? I feel fine. I don't want bad news, because there are simple things and natural things to do. Bergamot, berberine, aged garlic. I am a big fan of a supplement called pycnogenol, which is French maritime pine bark, but that's another topic. They're all mitochondrial support too. Yeah.
Yes. And so back to the mitochondria support. I mean, people are here viewing because they want to know how to improve their energy. And you and I know that if the heart is not functioning optimally, this is going to affect the way you experience energy throughout your day. You're going to have less energy throughout the day. You're going to have slumps throughout the day. So heart health is a really important part of this energy discussion. So could you talk about there's many directions we can go here in this conversation. We can talk about drugs that interfere with heart energy production. We can talk about lifestyle that interferes with heart energy production. Why don't you decide? Where do you want to go?
Since we brought up the topic of LDL cholesterol and statins, I mean, the point I'm making in the last 10 minutes is, you prescribe statins, I prescribe statins, drugs like Lipitor and Crestor. And in many cases, that's an absolutely appropriate thing. Somebody who's had bypass stents, somebody who has clearly identified a high amount of plaque they didn't know about, but the CT scan or the carotid scan showed it. Statins may be necessary. But I'll talk to you about an absolutely fascinating 2 pathways. Your liver is making cholesterol. Statins like Lipitor, statins like Crestor, some of the most widely prescribed drugs in the world. Not necessarily, a conspiracy theory. Most of these are generic, very inexpensive drugs. So it's not like big pharma making a ton of money. They used to. 25 years ago, Lipitor was a, major selling drug, but it's pennies in the generic world. So I want to take the money out of it and stick with the science. But you take that little pill called Lipitor because your internist says your LDL cholesterol is 130 and your grandfather had a heart attack and he's worried about you or she's worried about you. They've got good intentions. They're missing the fact they should get that CT scan first. there's this pathway called the mevenolate pathway. Nobody needs to remember that. And the drug, the Lipitor, the Crestor, partially blocks the pathway, so you make less cholesterol. Okay, that's all right. What everybody forgot in my biochemistry class in medical school 40 plus years ago is there's another branch to that pathway. It's like a fork in the road. The other branch is called the GG pathway. And I guarantee you this is all scientific and well described, but you never hear about it. Well, it turns out when you take Lipitor and you take Crestor, you not only block the full mevenolate pathway, so you make less cholesterol, you block the GG pathway. What does the GG pathway? It stands for geranyl. There is a biochemical name for it. The GG pathway makes CoQ10. And we just said CoQ10 is one of the most important mitochondrial support compounds, whether you make it, because we do make it as humans, or whether we take it as a supplement. So you're taking your Lipitor thinking, I'm doing this because my primary care doc tells me it's a good thing, or I really need to because I've had bypass or stents. But we're robbing our body of the ability to make coenzyme Q10, and you're going to get tired, and you're going to have less efficient mitochondrial function, and you maybe even will have a slight drop off in cardiac efficiency. There are some studies out there, not a lot, that the actual function of the heart may be slightly less efficient on statins, that people with congestive heart failure, who needs great mitochondria more than the hundreds and hundreds of thousands, millions of people that have congestive heart failure? And it's been shown if you take a person with congestive heart failure and put them on a Lipitor they don't need, you get no benefit. Maybe their arteries are clean, but you're actually causing mitochondrial damage, mitochondrial dysfunction, and you may actually worsen their congestive heart failure. So this extra pathway not only makes coenzyme Q10, it actually helps promote protein production. And, the heart muscle has to keep making more protein, repairing, restoring, rejuvenating its structure. And you actually, statins may impair, it's called protein prenylation. And actually down that pathway is actually vitamin K2 also, MK4, vitamin K2. So very exciting. Just recently, a scientist, colleague of mine, Dr. Barry Tan, found a plant in the Amazon. It's a beautiful red plant. Looks like a pomegranate almost, called the annatto plant, Annatto, I think you spell it. And it's been used to make a very pure form of vitamin E. But he found that there was a little residue, and it's actually pure geranyl, GG. So anyways, in my clinic, if I have to put you on a statin, I'm putting you on coenzyme Q10 and now commercially available GG to support your mitochondria, to support your coenzyme Q10, to support your protein prenylation. I source it out of a company in New Zealand. It's commercially available called GG Pure because they've just got it to the market in a very pure way. Anyways, and that's just like one example. We think we're doing something good for a person with a statin, and we're causing mitochondrial dysfunction, but we actually can remedy the mitochondrial dysfunction without stopping the statin if we need the statin. It's just using biochemistry more intelligently. So that's a fun little pathway.
It is. And so, Dr. Kahn, why isn't every cardiologist in America practicing like you?
Oh, it takes time. I'll tell you, I just thought of one other thing, because people, I'm not anti-Lipitor, but if you open the package insert, it'll tell you, you may develop muscle pain and aching. Mm-hmm. You may develop brain fog. It says it right in there, or cognitive impairment. And it talks about blood sugar elevation. And it turns out this GG pathway, which we don't want to block, but we have to if we're using Lipitor Crestor. If you restore the amount of GG with this supplement, at least in animals, blood sugar elevations return to normal. So it's hopeful that we may now have a strategy to deal with people who go on a Lipitor they have no choice to be on because they really need it, but they notice that their CG, their continuous glucose monitor, or their finger glucometer, or their blood work shows that their blood sugar stabilization has actually deteriorated a bit. It's a slow and steady process. I mean, I've been on a 10 to 12 year odd, course of a lot of expensive coursework, a lot of expensive meetings, a lot of reading. Mm-hmm. And you can do, they're doing good work. My colleagues are doing good work, but this idea of upgrading it and really bringing precision medicine to the bedside. As I say, I don't want to make it sound too difficult. Get about 10 extra blood tests, get 1 or 2 extra imaging studies like the heart calcium CT scan. You're welcome to read any of my blogs, your blogs. I'm always talking about, the science, where the other 2 vitamins that got very good recent reviews was omega-3 fatty acids and folate, along with coenzyme Q10. But CoQ10 is the mitochondrial miracle, so we'll stick with that as being the most scientifically backed drug. But
so many pearls.
Pharma, you know it, and I know it. Even though so much of what we've talked about are generic medicines, there still is the sales representative coming to the office with, they can't bring anything anymore but brochures, but there's still dinner programs at steakhouses. And, probably the biggest influence is when you go to national meetings and you just see, displays that cost hundreds of thousands of dollars and millions of dollars just to sell doctors on the idea that new expensive drugs are really safe and better. And we should be very skeptical about all that. I find that, as I get older and older, more and more offensive.
Totally. All right. In the last few minutes that we have here, let's talk prevention, because you mentioned at the beginning of this talk that you see a lot of people in your clinic who you're telling them you don't need to go on drugs. You just need to continue on with healthy lifestyle. So do you have a sense of statistically how many lives you're able to save and improve with the way that you practice cardiology?
Yeah, if you start stirring the pot, and again, we have recent and good science. If you there was just, again, another study happens to be again from Denmark, from Copenhagen this time, 10,000 people that they would put the hand on the Bible. I don't have heart disease. I'm over 40. I feel fine. I don't have heart disease. And you do one of these imaging studies, turns out about 50% have heart disease they didn't know about. So that's a lot what I do in my clinic. I take 50%, and I put them on a eat healthy, exercise, see in a couple of year plan, making sure their blood sugar and blood pressure are periodically monitored. But 50% have silent heart disease from minimal amounts to about 10% of the pie, 10% of the 10,000 actually had pretty serious heart disease they had no clue about, because we don't have a program. We don't have a mammogram of the heart, but we really do have a mammogram of the heart. It's called a heart calcium CT scan. And those people you got to work hard on. I think we make a major influence. Everybody knows somebody. Grandpa had a heart attack. Uncle Joe had a bypass. My mother had a stroke. Those diseases were identifiable 10 years before they got sick. And for a lot of them, I open their eyes that food is medicine. They might leave here with a brochure or a book. I might tell them to watch Forks Over Knives on YouTube, something really simple, but it's the first time in their life they made a connection. I maybe should upgrade my food, and the idea of standing desks and walking and motion in their life. And I spend so much time on sleep, because there's so much data now between poor sleep and atherosclerosis and early death and dementia. So it's about 50% of the people I'm seeing really need my ongoing care, and 10% of the pie really need my ongoing care. And I think that's substantial. I mean, if every doctor could identify 10% of their patient practice, they got 3,000 people in a family practice, and they're going to really impact 300 of the 3,000 in terms of risk heart attack, stroke. A big number. Then we can take that 1,000 people a day dropping dead. Maybe we only drop it to 700 a day dropping dead because we're, impacted. But, what a wonderful advance that would be.
It would be. Do you have a sense of how many stents are placed that are not needed, that could have, the problem could be solved with?
Yeah, I have the ability to comment on that as a very, experienced stent doctor. My rule to patients is, if you went to an ER and you got admitted overnight and they found you have a problem and they're talking about putting in a stent in a couple of weeks, you don't need a stent. You need a lifestyle program. You need a Dr. Dean Ornish heart disease reversal program or a Dr. Caldwell Esselstyn. You got to work with somebody carefully that knows what they're doing. If you're in an emergency room and you're having instability, or in a coronary care unit and they're telling you you're too sick, you can't leave, you're having your stent tomorrow, you're having your bypass on Tuesday, you probably need it and you shouldn't buck it. Although a few people, I've done some really high intensity consults from people in a coronary carrying it by FaceTime, trying to show me their data and make a decision if they have any room for a second opinion, even though they're in. But I do believe that the majority of these procedures, there's a world famous study published in about March of 2020 called the ischemia trial, ISCHEMIA trial, 5,000 people with very bad heart disease, but they were outpatients. Do you have to rush to the cath, the stent, the bypass, or could you treat them with medication, diet, and lifestyle? And at the end of 3.5 years, there was no advantage to rushing to cath or bypass. So the people that are well enough to be out considering their options should probably try and find a lifestyle-oriented preventive cardiologist and work with them or other practitioner. There just aren't many of us, and it frankly takes some serious cojones to work with a patient when the rest of the world is saying bypass, you're going to drop dead. And the reality, the science says very few of them are going to drop dead. I mean, I've never had anybody drop dead in that setting. Thank God. Thank you.
Yeah, well, on that note, I mean, I could keep asking you questions for the next hour, but we do need to wrap up. What I'm hearing loud and clear from you, if I was a consumer of healthcare watching this interview, what I would be hearing is I get to be my own best advocate. I get to read Dr. Joel Kahn's blogs. I get to research this, take notes from this interview, and go back to my health provider and advocate for myself. Because like Dr. Kahn just said, there aren't enough of him to go around to serve the millions of people in this country. So this is the big message here, is advocate for yourself.
I don't need to sell books. I have a nice practice, but a little tiny book called Dead Execs Don't Get Bonuses I wrote that sort of outlines the self-care program. What do I got to get? What tests to ask for? Why is a stress test not ideal compared to a CT scan? Little simple book with a crazy title, Dead Execs Don't Get Bonuses. But anyways, if we touch one person, we did a great job. I think we touched a lot of people.
We did. And thankfully, if you go back to your primary care doctor or your cardiologist and you drop, Dr. Joel Kahn, America's cardiologist, I'm reading his book. Could we, do some of the stuff he's recommending? Thankfully, you have a good reputation in this country and people know who you are and respect you. So name drop, I would say.
Thank you. Thank you. I had a good mom and dad.
Yeah. Thank you so much, Dr. Kahn. This has been wonderful.
Congrats on your wonderful summit.
Thanks. I want to thank you for your contribution as well to the world. Thank you so much for everything you do.